Hello students, welcome to Concepts of Care for Patients with Musculoskeletal Trauma, Part 2. This is a long chapter, okay? So this is a reflection of what's going on in healthcare. That's why this chapter is so long with the description of all different disorders. And musculoskeletal goes from fractures to injuries, to dislocations, strains, sprains. So we need to analyze all of them in detail. The good thing is that this can be a reference for you, so you can come back in any moment. And the purpose of these videos is to provide not only the concepts, but I am also submitting and providing videos, definitions, so you just need to play the video and let it go. Okay, everything is included in all these videos, so enjoy and take advantage of this type of technique that we are using to learn. Okay, traction is the application of a pulling force to a part of the body to provide bone reduction, or as a last resort to decrease muscle spasm, thus reducing pain. Patient interaction is often hospitalized, but in some cases home care is possible, even for skeletal traction. So although not frequently used today, the two major types of traction are skin and skeletal traction. Skin traction involves the use of a Velcro boot traction, and I think we can take a look to figure 44.5 is here. Let me see. Okay, skin traction with a hook and loop fastener is here, right? And then the other one is skeletal fracture, right? Screws are surgically inserted directly into bone. This allows the use of longer traction time and heavier weights, usually 15 or 30 pounds. Skeletal traction aids in bone realignment but impairs the patient mobility. Use pressure reduction measures and monitor for indications of impaired tissue integrity. Okay. So this box is NCLEX material. This is good to know, okay? Action alert. When patients are in traction, weights are not removed without a PCP order, okay? Weights are not removed. They should not be lifted manually or allowed to rest on the floor. Weight should be freely hanging at all times, okay? You don't touch that, nurses. Inspect the skin at least every 8 hours for signs of irritation or inflammation. When possible, remove the belt or boot that is used for skin traction every 8 hours to inspect under the device. Assess neurovascular status. How often we are repeating this? The patient's circulation is typically monitored every hour for the first 24 hours after traction is applied and every 4 hours thereafter. Okay, so this is the image we have of skin traction. And drug therapy is going to be opioid and non-opioid analgesics, your NSAIDs, and possible muscle relaxants. So for severe or multiple fractures, short-term patient control analgesia, your PCA pump with morphine, fentanyl, and hydromorphine is used. Oxycodone and oxycodone with acetaminophen or hydrocodone with acetaminophen are common oral opioid drugs that can be very effective for most patients with fracture pain. So for patients who have less severe injury, the analgesic may be given on as needed basis, PRN, right? Constipation is a common side effect of opioid therapy, especially for older adults. Assess for frequency of bowel movements and administer stool softeners or laxatives as needed for opioid-induced constipation. Encourage fluids, high fiber food, and activity as tolerated. Then we have physical therapy, collaborate with the physical therapist to assist with pain control and edema reduction by using ice heat packs, electrical muscle stimulation, and special treatments such as dexamethasone iontophoresis. Iontophoresis is a method for absorbing dexamethasone. This is a synthetic steroid through the skin near the painful area to decrease inflammation and edema. A small device delivers a minute amount of electricity via electrodes that are placed on the skin. So we are going to take a look to iontophoresis to better understand this. Okay.
Clean the skin in preparation for the electrodes. Ensure that there is no metal in the area to be treated. Using a syringe, inject the appropriate amount of medication into the pad. Place the electrode with the medication over the target tissue, and make sure the electrode is in full contact with the skin. Apply the other electrode and prepare to connect the leads. Attach the appropriate polarity lead to the active electrode. This is determined by the polarity of the medication. Turn the unit on and choose the appropriate parameters based on patient tolerance. The typical dosage is 40 milliamp minutes. Check in regularly with the patient and assess the condition of the skin. When the treatment session is complete, turn off the unit, gently remove the electrodes, check the condition of the skin, and assess the patient's symptoms.
Thank you so much. That was iontophoresis. Surgical management. For some types of fracture, close reduction is not sufficient, right? So surgical interventions may be needed to realign the bone to enhance the healing process. So in the preoperative care, we have to consider in the case of a patient undergoing orthopedic surgery is similar to that for anyone having surgery with general or epidural anesthesia. Okay, the care is similar, right? It's the same. Operative procedures for internal fixation uses metal pins, screws, rods, plates, or prostheses inside the body to immobilize a fracture during healing. The surgeon makes one or more incisions to gain access to the broken bone. A cast, boot, or splint may be placed to maintain immobilization during the healing process. So external fixation, we spoke before with close reduction, right? So we know that. And this is the internal fixation we are covering right now. After the bone achieves a union, the metal hardware may be removed, okay? So this is internal fixation. Okay, external fixation is a surgical procedure in which pins or wires are inserted through the skin, an affected bone, and then connected to a rigid external frame outside the body to stabilize the fracture during healing. Okay. External fixation is a surgical procedure in which pins or wires are inserted through the skin. That's why is external fixation. The pin is coming from outside an affected bone and then connected to a rigid external frame outside the body to stabilize the fracture during healing. Okay. After a fixator is removed, the patient may be placed in a cast, boot, or splint until healing is complete, or may undergo internal fixation. External fixation has several advantages over other surgical techniques. For example, and this is good to know, okay, there is minimal blood loss compared with internal fixation. The device allows early ambulation and exercise of the affected body part while relieving pain. Okay. The device maintains alignment in closed fractures that will not maintain position in a cast and stabilizes comminuted fractures that require bone grafting. A disadvantage of external fixation, that's good to know, NCLEX alert, is an increased risk for pin site infection. External fixation has the disadvantage of increased risk for pin site infection. Pin site infections can lead to osteomyelitis, which is serious and difficult to treat. Sometimes osteomyelitis, which is difficult to treat, can end up in amputation. Okay, be careful with that. Post-operative care, they are gonna start IV ketorolac, which is an NSAID, is a non-steroid and anti-inflammatory, and this is one of the most potent NSAIDs. Okay, ketorolac is often given in the post-anesthesia care unit in PACU. Patients who had a regional nerve blockade typically have little or no pain immediately after surgery for about 18 to 24 hours. However, when the anesthetic begins to wear off, be sure that the patient is medicated to prevent severe pain. Use non-pharmacologic measures for pain management, such as imagery, distraction, music therapy, and I think we spoke about this in previous chapters related to musculoskeletal. For patients with an external fixator, assess the pin size every 8 to 12 hours for drainage, color, odor, or severe redness, hyperpigmentation, which indicate inflammation and possible infection. In the first 48 to 72 hours, clear fluid drainage or weeping is suspected, which creates crusting around the pins. Okay, and you need to be comfortable with that presentation if you are working in a rehab unit or post-surgery. Procedures for non-union. Some management techniques are not successful because the bone does not heal. Several additional options are available to the primary healthcare provider to promote bone unions, such as electrical bone stimulation, bone grafting, and ultrasound fracture treatment. Electrical bone stimulation is a non-invasive external system that delivers a small continuous electrical charge directed toward the non-healing bone. There are no known risks with this system, although patients with pacemakers cannot use this device on an arm. Okay, and I have included a video about how human body creates electricity. So when they are doing this electrical bone stimulation, basically they are just promoting, okay, the creation and the activity of our electrons at electron neutrons in the cell. So they want to promote healing by controlling the electric impulse. There is a link here about electricity that you should be able to review. Bone grafting, in most cases, chips of bone are taken from the iliac crest or other side and are packed or wired between the bone ends to facilitate union. Allografts from cadavers may also be used. These grafts are frozen or freeze-dried and stored under sterile conditions in a bone bank. Low intensity pulse ultrasound used for a slow healing fractures or for new fractures as an alternative to surgery. Are other modalities. Also, ultrasound treatment has had excellent results. The patient applies the treatment for about 20 minutes each day. It has no contraindications or adverse effects. Let's watch this video really quick. Um, about the electricity. I just remember we have students from other schools that are following our videos, and they are not receiving the supplemental material, right? The medicine journal, how the human body creates electricity.
How do our bodies create electricity? The short answer is chemical energy. To understand why, let's look at the long answer. What most people think of as electricity is simply the movement of an electrical charge. To move, and as a result use the potential charge, we need an energy source. Some of the most common are hydroelectric, nuclear, solar and wind. Technological advances have allowed us to harness these sources, giving us wonders like computers and vibrating smartphones. The energy created by chemicals is due to the reactions of the atoms and molecules present. All of the elements we take in our bodies, like oxygen, sodium, potassium, and calcium, have a specific electrical charge, meaning they have a specific number of electrons, protons, and neutrons. Those specific charges, whether positive or negative, react to the charges of adjacent molecules. This reaction is what creates the energy needed to create electricity. When we eat or drink, the large molecules within our food get broken down by digestion, creating similar molecules. Those smaller molecules can be used by our cells to do work. This process is called cellular respiration. All of those molecules and elements in our bodies have the potential to create electrical impulses. Arguably, the most commonly mentioned electrical current within our bodies is the heart rhythm. Hearts contain, within them, a grouping of cells known as your sinoatrial node, or SA node. These cells within the SA node, sometimes called the pacemaker of the heart, contain electrolytes both inside and outside of the cells. The most common electrolytes within the body are sodium, potassium, calcium, magnesium, phosphorus, and chloride. Sodium and calcium generally reside outside of the SA node cells. Potassium generally lies within them. The cell membrane acts as a barrier between these electrolytes. Pressure within the bloodstream allows sodium to enter the cell, causing potassium to leave it. Less potassium leaves the cell than sodium entering it. The result is a continually growing positive charge. When the charge reaches a certain point, calcium channels in the cell membrane open up and allow for calcium to enter. This makes the interior of the cell extremely positive compared to the outside of the cell, known as an action potential. Once that potential reaches a certain point, it has enough power to discharge down the nerves of the heart. This electricity causes the muscles to contract and your heart to beat. Electrolytes crossing cell membranes, creating electrical discharges, is one of the countless ways the body uses the food we eat to create energy and power to do work. This is why the food content we eat is classified in calories, a calorie being a unit of energy. As technology advances, medical science will continue to unravel all the mysteries surrounding how the chemical reactions within our bodies maintain our daily lives and create our own bioelectricity.
Thank you so much. So you can understand right now why the importance of electricity in healing, right? And some electrolytes works in more specific areas. For example, in the case of calcium and phosphorus, it's related to the bones, right? Sodium, potassium related to the heart. And we have different other electrolytes and also supplements, vitamins, minerals that are going to be metabolized much better if the electricity is well controlled and maintained in the body. So let's continue. Increasing mobility. That's one of the things that we need to achieve in patients with fracture, and what we are going to do. The interventions necessary for this patient problem can be grouped into two types: those that help increase and promote mobility, and those that prevent complication of decreased mobility. Okay, so we can double check depending I am skipping these paragraphs because it all depends. Sometimes I truly believe that the explanation does not cover all types of fractures, all type of patient with comorbidities. So is the explanation in some areas should be more extensive, right? So it all depends on the type of fracture, the type of recovery, the health insurance of the patient, if the patient is having comorbidities, what is the extent of the injury. So all those factors should be considered in order for to help the patient increase and promote mobility, or to prevent complications of decreased mobility. Let's continue. So here we have the picture of assisting the patient with crutch walking. Okay, a walker is more often used by the older patient who needs additional support for balance. The physical therapist assesses the strength on the upper extremity and the unaffected leg. Strength is improved with prescribed exercises as needed. A cane is sometimes used if the patient needs only minimal support for an affected leg. A walker concept is an NCLEX Alert 1, and the cane. These questions is always in NCLEX. A cane, that's good to know. You need to know how to teach the patient how to use the cane. The cane is placed on the unaffected side and should create no more than 30 degrees of flexion of the elbow. The top of the cane should be parallel to the graded trochanter of the femur or stylus of the wrist. To ambulate, this is the important part, teach the patient to step forward with the cane and affected side at the same time for support. That's the most important. Okay, so you place the cane on the unaffected side, and then to ambulate, teach the patient to step forward with the cane and affected side at the same time for support. Okay, that's the most important. Preventing and monitoring for neurovascular compromise. The patient with a fracture is expected to have no compromise in neurovascular status, as evidenced by adequate perfusion, circulation, mobility, movement, and sensory perception sensation. If severe compromise occurs, the patient is expected to have early and prompt emergency treatment to prevent severe tissue damage. So what are the interventions? Perform neurovascular assessment, again, before and after fracture treatment. Patients who have extremity casts, splints, and elastic bandage wraps, and open reduction and internal fixation or external fixation, and are especially at risk for neurovascular compromise. If these symptoms are allowed to progress, patients are at risk for acute compartment syndrome, and we know what is acute compartment syndrome already. We discussed that extensively. So that's good to know. NCLEX maximum alert, here, this box, critical rescue, monitor for and document early clinical cues consistent with acute compartment syndrome. If early indicators are not recognized, ACS may progress and result in the 6 P's: pain, pressure, paralysis, paresthesia, pallor. Pain, pressure, paralysis, paresthesia, pallor, and pulselessness. So those are the 6 P's: pain, pressure, paralysis, paresthesia, pallor, and pulselessness. Okay, as a result of decreased arterial perfusion to the affected area. If acute compartment syndrome is suspected, notify the PCP immediately, and if possible, implement interventions to relieve the pressure. If the patient has a cast, follow agency protocol about how may cut the cast. About who may cut the cast. Yes, it's not that the nurse is deciding, okay, I see there's signs and symptoms of compartment syndrome, let me get the scissors and I'm gonna cut the cast. That's not the way it works. You need to find the protocol, the agency protocol about who is authorized to cut the cast. Do not elevate or ice the extremity because that could compromise blood flow. Okay. Care coordination and transition management. The patient with an uncomplicated fracture is usually discharged to home from the emergency department or urgent care center. Older adults with hip or other fractures or patients with multiple traumas are hospitalized and then transferred to home, a rehab setting, or a long-term care facility for rehab. Be sure to communicate the plan of care clearly to the healthcare agency receiving the patient using the SVAR. And this is not only for musculoskeletal patients. It's a practice, it's a protocol that is in place in most hospitals whenever you give report at the end of your shift. SVAR, situation, background, assessment, and recommendation. Okay, you're going to describe the situation of the patient, how this happened, the assessment during their shift, if the recommendation, in your shift, this patient may need extra opioid medication, try to, follow up because this patient is exhibiting signs and symptoms of delirium. Sometimes the patient wants to get out of bed without authorization, whatever it is. And I recommend you to put your work unit in the door of this of the patient's room, something like that. Okay, so communication method or other agency specific system. Home care management. If the patient is discharged to home, the nurse, rehabilitation therapist, or case manager may assess the home environment for structural barriers to mobility, such as stairs. But this is kind of difficult sometimes, and I would say most of the time. When I used to work as a nurse in home health care, most of the patients that were recovering from these musculoskeletal traumas were transferred to long-term care facilities or maybe rehab centers, because sometimes you cannot arrange the environment, you cannot put all the equipment needed at home. Ask about small pets, scattered racks, wax floors, and walkaway areas that could increase the risk for falls. If patients need to use a wheelchair or other ambulatory aids, make sure that they can use them safely and that there is room in the house to ambulate with these devices. Yes, and especially if they are living in a building, you have to make sure the building has elevator, and you need to coordinate for home health aid to come and visit the patient and to help the patient organize the home. Self-management education. The patient with a fracture may be discharged from the hospital, emergency department, office, or clinic with a bandage, splint, boot, or cast. Please provide verbal and written instructions on the care of these devices. Also need to continue wound care at home, but most important, please make sure the language of these instructions are within the understanding of the patient. Okay, and also make sure the patient doesn't have visual issues. If there is vision problems, you can give the instruction in the language of the patient, but it's not going to be able to read them. That's good to know. Encourage patients and their families to ensure adequate foods high in protein and calcium that are needed for bone and tissue healing. This is very important. Tissue healing depends on high protein and calcium. For patients with lower extremity fractures, less weight bearing on long bones can cause anemia. For patients with lower extremity fractures, less weight bearing on long bones can cause anemia. The red bone marrow needs weight bearing to stimulate red blood cell production. That's why sedentary life is not good. You need to walk. Encourage foods high in iron content. Teach the patient to take a daily iron added multivitamin. Take with food to prevent possible nausea. and a stool softener with a stimulant to prevent opioid-induced constipation. That's good to know. This entire paragraph is NCLEX material, good to know. I feel like I want to test you on this. Okay, so we have another question. The nurse is teaching the client who had a right closed tibial fracture. Right closed tibial fracture repair. How to walk with a cane after cast removal. The nurse is teaching a client who had a right closed tibial fracture repair on how to walk with a cane after cast removal. Which statement by the client indicates understanding about the health teaching? I should use the cane on my left side for support when I walk, because remember, you place the cane on the unaffected side, and he had the affected side for this patient is the right, so this is the right question, the right answer. Okay, healthcare resources. An older or incapacitated patient may need assistance with ADL, which can be provided by home care aides if family or other caregivers are unavailable. And you also can provide some websites with information. How you evaluate the outcomes. So you need to make a list with the priority for the patient. And here is a box, home health care for the extremity after cast removal. So you teach the patient to remove scally, dead skin carefully by soaking, do not scrub. Because at the end, if you do otherwise, you're going to get infected. Move the extremity careful. Support the extremity with pillows. Exercise slowly as instructed by your physical therapist. Wear support stockings. And that's important. Also, we are going to evaluate the outcomes by asking the patient and also do the assessment, and we need to find the pain control 2 to 3 on a scale of 0 to 10. We need to see the patient ambulates independently with or without an assistive device. The patient is free of physiologic consequences of decreased mobility. Patient has adequate blood flow to maintain tissue perfusion and is free of fracture complications. Let's get into low extremity fractures. Hip fracture is the most common musculoskeletal injury in older adults and one of the most frequently seen injuries in any healthcare setting or community. Hip fracture. It has a high mortality rate. Hip fracture as a result of multiple complications related to surgery, depression, and decreased mobility. Hip fracture, high mortality rate, older adults. Pathophysiology review. Hip fracture include those involving the upper third of the femur and are classified as intracapsular within the joint capsule or extracapsular outside of the joint capsule. In the area of the femoral neck, disruption of the blood supply to the head of the femur is a concern, which can result in ischemic or avascular necrosis, and you know that. And this is happening of the femoral avascular necrosis of the femoral head. Avascular necrosis causes death and necrosis of bone tissue and results in pain and decreased mobility. Okay, so here is a graphic types of hip fracture. We can see the one that is intracapsular within the joint capsule, and we see the one extracapsular outside the joint capsule. Okay, this is a very nice picture. It's very descriptive. Osteoporosis is the biggest risk factor for hip fracture. Osteoporosis minus 2.5 and less in DEXA. This disease weakens the upper femur hip, which causes it to break and lead to a fall. In some cases, a fall causes the fracture of the weakened hip, often referred to as fragility fracture, and we spoke about this. Fragility fracture is caused by most of the time by bone cancer and osteoporosis, right? So patient-centered care, older adult health, teach older adults about the risk factor for fragility hip fracture, right? So physiologic changes include sensory changes such as diminished visual acuity and hearing. I told you visual is very important, hearing is very important, but when they need to read the instructions, they need their vision and they need their language. Change in gait, balance, and muscle strength and joint stiffness. Disease processes such as osteoporosis, food disorders, bony metastases, and changes in cardiac function increase the risk for fracture. Food disorders like plantar fasciitis that we learned before, right? Drugs such as diuretics, antihypertensive, antidepressants, sedative, opioids, and alcohol are factors that increase the risks for falling in older adults. So whenever you do your assessment, you need to get the full list of medications, and probably they are not going to remember. So you ask the patient to bring a box or a bag with all the medications and you just take notes, okay? Throw rags, loose carpeting, floor clutter, inadequate lighting, even uneven walking surfaces or steps, and pets are environmental hazards that also cause falls. And why pets? Because they need to take the pet out for, you know, for when they go out for walking. So if the pets start running, we never know what's going to happen in the street. The older adult with hip fracture usually reports growing pain or pain behind the knee on the affected side. In some cases, the patient has pain in the lower back or no pain at all. However, the patient is unable to stand without pain. X-ray or other imaging assessment confirm the diagnosis. The older adult with hip fracture usually reports growing pain or pain behind the knee on the affected side. So you just, if you know this, you know that you need to take the patient, if it's a family member, take the patient to the ER for x-ray to be done immediately. Okay, assessment, assessment, assessment. Interprofessional collaborative care to relieve pain by reducing and immobilizing the hip fracture. So those are the steps, right? We need to control the pain by reducing and immobilizing the fracture. Almost all patients have surgery, and older adults are high-risk surgical patients because of physiologic changes of aging and multiple comorbidities. We know that. Preoperative care, what are we going to do? Our IV opioid after admission, and they may receive morphine or hydromorphine. And also a preoperative alternative to opioid is fascia iliaca compartment block, a regional anesthetic technique to block femoral, lateral, cutaneous, and obturator nerves. Look the amount of nerves. Block femoral, this is an artery, lateral cutaneous, and obturator nerves. So you have the artery and the nerves. This procedure avoids the risk of injury to the femoral artery and vein. The benefits of the fascia iliaca compartment block include effective pain relief without opioids and minimal cost. So this is excellent for older adults because sometimes with age, the patients are having this delirium, or decrease mental status, and if you prescribe an opioid, this condition is going to worsen, right? So this is a good choice, fascia iliaca compartment block. Okay, postoperative care, the treatment of choice is surgical repair by ORIF, open reduction, internal fixation, when possible, to reduce pain and allow the older adult to be out of bed and ambulatory. ORIF is open reduction, internal fixation, right? Before and after a hip repair, older adults frequently experience acute confusion, delirium. That's what I was telling you. They may pull at tubes or the surgical dressing or attempt to climb out of bed, possible failing and causing self-injury. Other patients stay awake all night and sleep during the day. Keep in mind that some patients have a quiet delirium. Monitor the patient frequently to prevent falls. I've seen it in the hospital, in the rehab unit, a patient that was recovering from a fracture, and the patient was in traction, and then when she was going to be discharged, of course she was out of the traction and everything was good. So but the provider and the nurses, they didn't assess properly the mental state. So one day before discharge, the lady called the bell to go to the bathroom, and the CNA came, help her, assist her to go to the bathroom. Remember that they need to monitor how she was walking. So she was sitting in the toilet, and the CNA decided to give her privacy, which was not recommended. And the patient that was sitting in the toilet started to scream out of nothing. Mental status was not properly assessed. She started screaming because she felt scared that the CNA stepped out of the bathroom, and she fell in the bathroom. So she got another fracture. This is a real case, real scenario. Okay, so you need to monitor this. And I don't want to tell you what happened to the nurse and the CNA. Okay, protect the patient, protect your license, do your job. Okay, so this is the hip prosthesis used for femoral head or neck fractures. There's the compression hip screw used for open reduction and internal fixation. You see, basically they repair the bone with these screws, but the it's not the same as getting the hip prosthesis, right? There is no risk for subluxation. Okay, let's continue. So, patients who have a herniatoplasty for fracture hip repair, herniatoplastic for fracture hip repair. Okay, okay. Are at risk for hip dislocation or subluxation. Yes, so this is the one, the ORIF. Be sure to prevent hip adduction and rotation to keep the operative leg in proper alignment. Yes, so when this is done, the open reduction and internal fixation is the same bone they are using. So the patient is in risk for dislocation or subluxation. Regular pillows or abduction devices can be used for patients who are confused or restless. If straps are used to hold the device in place, make sure that they are not too tight and check the skin every 2 hours for signs of pressure. Perform neurovascular assessment to ensure that the device is not interfering with arterial circulation or peripheral nerve conduction. So you have your 6-piece neurovascular assessment. There was a box in this chapter mentioning the 6-piece, and I am right now playing a video. This is so important. that I am repeating this over and over again.
The 6 P's of neurovascular assessment. A neurovascular assessment, which is also called a circ check, is performed to determine if there is an adequate circulation and sensation to an extremity. Here are the 6 P's to neurovascular assessment. Pain. Pain is the universal symptom in compartment syndrome. It may be related to edema, movement of bone fragments, or muscle spasms, and it increases as the pressure within the limb compartment rises. Pain is represented by the pain bolt. Paresthesia. Paresthesia is often the first sign of an impending problem described as the pins and needles sensation that may include numbness or tingling as a result of inadequate circulation. It may also be a sign of nerve damage and professing compartment syndrome. Paresthesia is represented by the Paris t-shirt for pins and needles. Pulse. Pulses should be compared for differences in rate and quality on both the unaffected and injured extremity. A diminished or absent pulse distal to the injury may indicate vascular dysfunction and insufficiency and should be reported immediately to the provider. Pulse is represented by the heart timer. Pallor. Pallor refers to the color of the extremity, pink, pale, cyanotic, and should be assessed along with temperature, hot, warm, cool, cold, against the unaffected side. Pale, shiny skin distal to the injury may indicate compartment syndrome, while a warm cyanotic extremity may point to a poor venous return. Pallor is represented by the pale with pallor. Pressure. Increased pressure may indicate compartment syndrome and is related to swelling within the cavity. Depending on the severity, this may result in a feeling of numbness or a loss of sensation in the extremity or cause severe pain. Pressure is represented by the pressure cooker. Paralysis. Partial or full loss of sensation of function may be a late sign of neurovascular damage. The complete inability to move the limb distal to the injury may indicate compartment syndrome, and significant muscle and nerve damage may be present. Paralysis is represented by the wheelchair. So there you have a quick hit list of memorable characters to help you remember the 6 P's of neurovascular assessment. Need an easier way to help remember neurovascular assessment? Be sure to check out these and tons more inside Picmonic.
Thank you so much. That was excellent. So not only they refresh your concepts of the 6 P's, but also they go deep into what is the meaning of each P. Excellent, excellent, excellent. So other fractures of lower extremity, we have if the patient has severe or multiple fractures, especially with soft tissue damage, hospital admission is usually required, right? So best practice for patient safety and quality care, indicators for post-operative nursing care or of older adults with hip fracture. So you have the timing of surgery. You have your nursing interventions within 24 to 48 hours of the fracture, depending on the patient's condition. You have to make sure the patient got a surgery within this period of time. Early and frequent mobility assists the patient to get out of bed to stand. Malnutrition prevention, catheter-associated urinary tract infection, and you can go deep in this in reviewing this table. And also pneumonia prevention. I will take a look in the ones that are hospital-acquired conditions, for example, catheter-associated urinary tract infection, your pneumonia prevention, keep the head of the patient's bed elevated to at least 30 degrees, perform dysphagia screening, and provide frequent mouth care. And just to refresh your knowledge, remember that we need to be very familiarized with medical terminology. Dysphagia refers to difficulty swallowing, and some people, they confuse dysphagia with dyspepsia. Dyspepsia refers to discomfort or pain in the upper abdomen, okay? An easy way to remember is pepsia, peptic ulcers, dyspepsia, upper abdomen, right? Regurgitation or the sensation of acid backing up into your throat or mouth. So I wanted to include regurgitation just in case because these are the three terms that I find usually students getting confused with dyspepsia, dysphagia, regurgitation. Okay, so also your venous thromboembolism prevention, all the nursing care and interventions to prevent those. Fractures of the lower 2/3 of the femur usually result from trauma, often from a motor vehicle crash. Immobilized by casting because the powerful muscles of the thigh become spastic, which causes displacement of bone ends and significant pain. Extensive hemorrhage can occur with femur fracture. The surgical treatment is ORIF, open reduction, internal fixation. In case of sometimes external fixation is going to be used. Healing time for a femur fracture may be 6 months or longer. Skeletal fracture also can be considered. Trauma to the lower leg most often causes fractures of both the tibia and the fibula, okay? Particularly the lower third, and is often referred to as tib fib fracture. The major treatment techniques are close reduction with casting, internal fixation, and external fixation. The patient is typically non-weight bearing and uses ambulatory aids such as crutches. So they are giving us a list of different types of fractures and trauma. We were analyzing the lower 2/3 of the femur. We are analyzing trauma to the lower leg. Right now we are going to see the ankle fractures are described by their anatomic place of injury. For example, a bimalleolar pod fracture involves the medial malleolus of the tibia and the lateral malleolus of the fibula. The small talus that makes up the rest of the ankle joint may also be broken. So an ORIF is usually performed. Weight bearing is restricted, of course, until the bone heals. And then we have the treatment of fractures of the foot or phalanges is another area. It's similar to that of other fractures. Phalangeal fractures may be more painful, but are not as serious as most other types of fractures. Crutches are used for ambulation if weight bearing is restricted, but many patients can ambulate while wearing an orthopedic shoe or boot while the bone heals. Okay, let's stop here, and then when we come back, fractures of the chest and pelvis.